second.
I think we are ready to go. I just started the
Okay, let me try this
transcribe.
one more time. I'm so sorry. I am not. Okay.
There we go.
This. Telling me.
I can give a brief introduction, though I don't think either of you really need it. But thank you guys so much for joining us here. We have two wonderful speakers, Dr. Walsh and Dr. Kosowsky. I know we have some interns on the call, so maybe not all of you have met Dr. Kosowsky, but he's one of our amazing, especially EKG educator, but amazing educator in general. So thank you guys so much for joining us, and they'll be presenting on an exciting case of bradycardia. So whenever you guys are ready.
Thank you. While we're waiting for Lindsay to get the slides up and running,
my goodness.
I'll just give a little bit of background. So this was a case that inspired some discussion about how to think about severe bradycardia and some of the consequences and management decisions. So it was a case that initially I saw with Marie White, one of our fantastic PAs at the Brigham last week. And as the patient became more critically ill, thankfully Lindsay was there and was really helpful in helping us think through the case and manage the case. And then when we debriefed afterwards, we thought this would be a fantastic sort of launching pad for discussions of bradycardia and resuscitation in general. I don't know if Marie's going to be able to join us because she's working clinically, so she may or may not be able to hop on the call. But without further ado, I'll ask Lindsay to start out by sort of walking through a bit of the timeline and sort of like we do with M&M or trauma. And the only difference here is that it's not nearly as formal. Morning report in general is meant to be more of a discussion than a didactic lecture. So please unmute. If you can be on camera, even better, and raise questions or comments as we go through. We have the whole hour. We may not need the whole hour, but certainly would welcome all kinds of comments and conversation. So let me turn over to Lindsay, and we'll get started.
Great. Can everyone see my screen?
Okay. Yeah, we can see it. Great.
Perfect. Good morning, everyone. Thanks for the introduction, Dr. Kosowsky. This was an interesting case that I'm excited to present, and we welcome thoughts and feedback. A caveat, I am post overnight, so if anything I say does not make sense, it's highly possible. Feel free to ask questions and I can clarify. So without further ado, let me tell you about our agenda for today. So this is Beware of the Block, a case of unstable bradycardia that we encountered last week in Exeter. So our agenda for today is pretty straightforward. We will summarize an interesting patient case. We will discuss the treatment of unstable bradycardia, including both medical and electrical management, and then share the outcome of this case as well as some important lessons learned. So in terms of the patient case, this patient was categorized as an ESI 2, and the triage note talked about an 83-year-old male with a history of AFib who had undergone an ablation, currently on Eliquis, history of a left bundle, hypertension, hyperlipidemia, a recent right temporal bone fracture, who was brought in by EMS for witnessed syncope. And the provider HPI I mentioned that this individual was walking outside this morning when he had a syncope that was witnessed by bystanders. He denied any prodromal lightheadedness or chest pain. He woke up on the ground. He endorsed lightheadedness and nausea at this time. For EMS, his heart rate was in the 30s when they sat him up on scene. And for EMS, the rhythm strip was concerning for a second-degree heart block. His initial vitals in the ED were largely unremarkable, as you can see here. His pulse was noted to be 68 at first, and his blood pressure was hypertensive.
Let's just stop right there just for a second.
Yeah.
I just want to point out a couple of things.
Sure.
So number one, I went to think about the fact that the heart rate's listed in the 30s, but the pulse is listed as 68. Think about what that might mean. Well, actually, we'll show you an EKG later on that may help you think about that, but always sort of raises some questions. So I want you to think about that. Think about the fact that this was a case of syncope, and yet the blood pressure looks pretty stable. So think about what the implications of that might mean. And then two other things I'll just add to the history, because we knew this right up front, was that that this recent temporal bone fracture was after another syncopal episode. So this was not his first rodeo with syncope.
Great. So just a couple things to note on the physical exam that I've highlighted here. In terms of cardiovascular exam, Marie, the PA who initially saw him, noted that on the monitor he was, at times Brady to the 30s with improvement to the 50s to 60s without intervention. He had a regular rhythm without murmurs, rubs, or gallops, and he had 2+ radial pulses. On his MSK exam, since he did have this, syncopal episode, he did have tenderness over the right posterior elbow. And he also had abrasions to the right posterior shoulder and right upper thoracic midline back, and he had a skin tear over the right elbow as well. But his neuro exam was benign. He was intact. He had his GCS of 15, and he had 5 out of 5 strength in the upper and lower extremities. So I was wondering if anybody would be willing to, share their thoughts on this initial EKG. This was the first EKG that was obtained for this patient when he arrived in Exeter.
I only see one intern on the call, so unfortunately, Spencer, if you're able to unmute, can you see the screen? So you've got two excuses if you can't do it, but you're around, Spencer?
I'm in my car right now.
In your car,
hello?
there you go. Okay.
I'm in my car right
I don't want you
now.
to get into
I
a
can
crash.
see it. No, I just pulled over to the side of the road. Let's see. So I'm interpreting the CKG.
If you are safely able to do so.
Max could tag team with you.
Currently,
Yes.
I'm parked in a spot on the
Max is
side.
on
So
too. Okay, great.
Oh no.
But let's see. So rate, rhythm, and axis first. So
Yep.
rate, I'd say, is bradycardic. Let's see how many little boxes between. It's irregular. 1, 2, 3, 4, 5, 6, 8. So 300 divided by 8. So like 40-ish would be the rate. Rhythm, irregular. Axis, not normal axis. I'd say negative axis. So there's some deviation to the right. Let's see, what else do we see? We see some prolongation of the QT, potentially. I don't really see maybe I see a P before my QRSs. Definitely abnormal EKG.
Right, not bad for looking on your phone.
Yeah.
It's a good start. Anyone else want to jump in with other thoughts?
In terms of rhythm here, like looking at the rhythm strip on the bottom, I definitely see P waves. So it's sinus. I think that they're like the PR interval is slightly prolonged, and I think it's a 2-to-1 block right now. Just trying to march out those.
Yep.
Yeah, so as a general rule, it's helpful if you can sort of separate the atrial activity from the ventricular activity, even if they are linked, but to sort of think about them separately. So if you look at the atrial activity, you see P waves that march through quite regularly at a rate of about 60 all the way through. And then you can see that some of those P waves are followed by a QRS and some are not. Some are not. And then the question is, if they are followed by a QRS, are they happening in a coordinated way, like they're actually being conducted, or is it just chance? It looks like they're actually being conducted, because if you look at almost every QRS is preceded by a P wave. In fact, every single one of them, but not every P wave is followed by a QRS. Does anyone want to give a name to this rhythm?
I would call it a Mobitz type 1.
Okay, what can you say more about that?
So I think it's a second degree block. I think there is a little bit of PR prolongation, but it doesn't look progressive to me.
Right, so it's actually impossible to say, just based on this, whether it's Mobitz 1 or Mobitz 2, because you don't have prolongation of the PR, so it could be Mobitz 1 or Mobitz 2. We're probably not going to get into this level of detail for purposes of this. And the fact that the QRS is wide would normally make you think this is Mobitz 2, but because you guys are underlying left bundle branch block, that's kind of off the table. What you do see is that it's pretty high grade block, because it's at least 2 to 1, and in some places 3 to 1 block. So it's probably more likely Mobitz 2. But you can't absolutely say it's not Mobitz 1, because you don't have enough PRs in a row to say that they're prolonging. You just have drop PRs after every conducted peak. Does that make sense? Again, we don't want we could spend the whole hour just talking about different types of block, but for purposes of the case, let's move forward. But the bottom line is this is pretty high grade AV block, and severe bradycardia.
Yeah, and everyone who helped interpret this did excellent. Thank you guys for your input. Some initial labs for our gentleman here. Not going to spend too much time on this, but his initial troponin was, mildly elevated. Otherwise, nothing super significant stands out, so I am going to keep going. I tried to structure this like our timelines for trauma cases and M&Ms. To give an overview, you can see the time that the patient was roomed in Exeter 49 and the time of the first EKG that we just went through. Cardiology was consulted about 20 minutes later, and his episodes of bradycardia and this, high degree block was discussed with cards. An EP consult was also placed, and the plan was ultimately to admit the patient to cardiology unless there was a significant trauma burden. He had also been ordered for like a CT trauma pan scan as a result of this fall and the fact that he was anticoagulated. There was high concern for injuries, especially with the anticoagulation. So the decision to move forward with scans without waiting for his creatinine to result was made. Shortly thereafter, he became more profoundly bradycardic. He got 1 milligram of atropine at 10:54. And his heart rate at that time was documented to be 26. He was still noted to be mentating appropriately, but the heart rate did not budge with atropine. So after discussion with our pharmacy colleagues, he was started on a dopamine infusion. Sometime later, to the tune of about 10 minutes, his heart rate remained in the 20s to 30s without any significant improvement. So isoproterenol was started, again with pharmacy at bedside and discussion with them. The decision his heart rate again remained in the 20s to 30s. His blood pressure was downtrending at this time. So the decision with now, increasingly unstable bradycardia was made to transcutaneously pace him, giving his declining blood pressure and now his, waning mental status. He was started on an etomidate infusion for sedation. Cardiology members of the EP team, our pharmacists, our nurses were all at bedside at this point. And as we started transcutaneously pacing him, the decision to try to move forward with, an urgent pacemaker placement was also made. There was some difficulty obtaining electrical capture with the transcutaneous pacing. We increased the milliamps, and we were still not really seeing pacer spikes at that time. The hypotension remained. He was minimally responsive. So all of these things considered, at 11:57, we decided to intubate him for airway protection and declining mental status. So he already had etomidate on board. We gave the full dose for intubation for RSI along with rocuronium for paralysis. So he now had a stable airway, and then he went for his CT imaging, which revealed a small left frontal subarachnoid without any midline shift. So neurosurgery was consulted. There was a discussion about whether or not to reverse him. And the decision was made with pharmacy to not proceed with that at the time. He underwent a stability scan. He was, I guess, admitted, the technical phrase, but he went to the EP lab where they tried to put a pacemaker in, which I'll talk about later. And then the plan was to hopefully get him for the pacemaker and then extubate him with EP if possible. Dr. Kosowsky, any comments here?
Yeah, I mean, you can see how this played out over a couple of hours, and we'll talk more about why things got worse. His heart rate, as noted here, continued to trend downward, and when he was in rates in the 20s, it was still second-degree block, but it was just 3-to-1, 4-to-1, 5-to-1, so pretty scary. As noted, he was starting to show signs of shock, not just his mental status, but his perfusion distally was at cool, clammy extremities, and just was looking sicker and sicker. So that's essentially why everything sort of escalated. But it happened with sort of a slow escalation. Maybe we'll talk about in retrospect whether we could have predicted this sort of likely outcome, but. Ultimately, we were able to get capture. So by the time he was intubated, he actually had heart rate in the 60s or 80s. I don't remember exactly where we were pacing him at, but he had a good blood pressure and he was stable for intubation. Otherwise, it would not have been safe to intubate him when he was in shock.
All right. So a repeat EKG was obtained around this time, which this was before we started pacing him. This was like when he was becoming more and more unstable. For the sake of time, I will probably not go through this, but just put it here to kind of, show the progression of the case.
And the only thing I point out here is that, his effective heart rate here is about 20, even though if you count up the beats, it looks like maybe 40. But he's having, those two beats in sequence are probably not very effective. And so if you actually felt his pulse, it felt like it was 20, even though his heart rate may have been not, his electrical pulse was 40.
Right. That's a good point. And then this is just like a high level rapid review. Just keeping in mind with the EKGs that we've discussed, the EKG criteria for the major types of bradycardia. So we know that first degree, it involves PR prolongation.
You froze, Lindsay.
Oh, what's happened?
You're back, I think.
You're back. Or not.
Can you guys hear me?
Yeah, we can hear you now.
I'm sorry, I think my Wi-Fi dropped for a second. This is like the all factors working against me this morning. Okay. So yes, the different types of heart block listed here. And then Dr. Kosowsky, do you want to talk a little bit about symptomatic versus asymptomatic bradycardia, stable, unstable, just giving a brief overview?
Yeah, I think, we're all familiar with ACLS, and I think we're pretty good at determining whether patients are stable or unstable. I think the plug I want to make here is not to be fooled by blood pressure. We know that that's true with other types of shock, patients who can be in septic shock and have a normal blood pressure till the end. Certainly in trauma, patients can be in shock with normal blood pressure. The same thing is true with unstable bradycardias. So obviously, when you think about arrhythmias and cardiac output, the cardiac output is equal to the heart rate times the stroke volume. We all remember that from basic physiology. With bradycardia, by definition, the heart rate is low. The stroke volume is actually often a little bit increased because there's more filling time. So as opposed to tachycardia, where the reason why you end up with hypertension with unstable tachycardia is because the stroke volume is low. With any kind of bradycardia, stroke volume is not an issue. In fact, stroke volume may be a little bit higher. But with severe bradycardia, because the heart rate is so slow, you just don't get enough perfusion over the course of the full cycle, even though each beat itself has plenty of output. And so when you think about the blood pressure is looking at what your systolic and diastolic pressure is at any given beat. And so if you're just going to think about it holistically, if you're only having, say, 20 beats per minute, yes, you may have a systolic pressure of, say, 140 for that period of time when systole is occurring, but systole is only occurring, for rather than occurring for about 50% of the time in a normal heart rate, it's only happening for maybe 25% of the time. So most of your time is going to be in diastole, which means that your effective, when we think about mean arterial pressure, we usually have a formula that takes 2/3 of the difference, but that assumes that you have a regular rate. If your rate is really low, most of your time is in diastole. So the actual perfusion pressure at any given time is usually your diastolic pressure. So if your blood pressure in this case was initially 160/80, and later on it was maybe looked normal, it was 120/70. But most of the cardiac cycle, his blood pressure was 70. You got to keep that in mind in patients with severe bradycardia. And because of that, you need to look for other signs of shock other than the blood pressure. So in this case, his mental status started out being pretty normal, and then he was noted to be a little more anxious, and then just slightly more confused. I mean, it was pretty subtle, but his mental status was definitely, if you had noticed it over time, was definitely becoming more and more abnormal. And I mentioned before, like his peripheral perfusion, his extremities were cool and clammy. The pulses that you felt were strong, but again, most of the time you weren't feeling the pulse.
Mm-hmm. Yeah. And I think that's one of the key points here in this case. And for some reason, this one is not showing up. I think the slide I had here was kind of a nice diagram from EM Crit that I'm happy to send out, but it essentially just reiterated that bradycardia is a spectrum, and being able to recognize that spectrum, as Dr. Kosowsky pointed out, is important, especially in the ER, where we have stable symptomatic patients with bradycardia, and then patients with bradycardia that are in profound shock and progressing towards arrest, and that it's important to be able to recognize, what those signs of shock are, as he just illustrated. And when we do start to talk about bradycardic patients who are in that shock state, there are two major arms of therapy, which involve medications in one treatment arm and electricity in the other treatment arm. And the overarching summary of this slide is that it is encouraged and okay to proceed down, both of those treatment routes simultaneously, with the goal of stabilizing the patient if possible. So we're going to talk about some of these medication options as well as transcutaneous pacing, and then talk a little bit about transvenous pacing as well. So there are a host of medications that can be considered for bradycardia. I am guessing people are somewhat familiar with atropine or have heard about atropine, being proposed in the ED setting. This is a med where if you have it available, which typically is the case in most EDs, to my understanding, it's okay to try it. But remember that atropine works at the level of the vagus nerve, so it's typically only effective in cases of bradycardia where there's excessive vagal tone. The maximum dose to give is 3 milligrams, which is just important to remember. You can start with a 1 milligram dose, and then additional doses can be given after that to the max of 3. Another med that might be frequently talked about is epi, which has a major advantage in the sense that it is available in most places as well, in code carts and things like that, which we'll talk a little bit about. And unlike atropine, epinephrine stimulates the entire myocardium. So it typically has a broader spectrum of efficacy versus a medication like atropine. And it's important to note that it is safe for peripheral infusion. You don't actually need a central line to use it, which is helpful in, you're crashing your unstable patient. I'm not going to get into the weeds with doses, but the usual dose somewhere between 2 to 10 micrograms per minute, but there's no hard and fast upper limit if the patient is crashing. And figuring out how to achieve your epinephrine access wherever you end up working is important. And then a slide later on, we'll talk a little bit about, preparing your own epi drip if you're in the community. Calcium is also something that you can give. It's often underutilized in bradycardia. It can be given IV as well. If the cause of the bradycardia is unknown, starting with 1 round of calcium, which would be like 1 gram of calcium chloride or 3 grams of calcium gluconate, is recommended. But if you have a clear etiology, if it's something like hyperkalemia, you can increase that dose and look for a response, whether it's EKG changes that you're looking for and things like that. Just a couple of other meds to highlight. Dobutamine is a beta agonist, which can be used in patients with bradycardia, but it should be avoided in patients that are hypotensive because it can cause vasodilation, which will worsen your hemodynamics. And then there's also isoproterenol, which I've actually never seen used until this case. And it's per EM crit, a very good drug to use in cases of unstable bradycardia since it's a pure beta agonist. It's also safe to use peripherally. The major drawback, to my understanding, is that it's very expensive and it's not widely available at most emergency departments, but we happen to have it at Brigham. And then another medication that was used in this case was dopamine, which is another med that can be used in bradycardic patients. It's stable at room temperature, which is important. It's often available in pre-mixed bags. EMS will carry it sometimes. At high doses, it can be a vasoconstrictor. At low doses, it will vasodilate. And it's important to note that it can cause skin necrosis if used for prolonged periods of time. So that's a side effect to be mindful of if you are using it for a patient. So this is just an infographic summary of some of the medications that are available for your unstable bradycardic patients. And then this is a nice EM crit infographic that I think Sangeeta actually has talked about before during some of her didactic lectures last year. I'm not going to get into the nuts and bolts of this, but EMCrit does have a nice page available for how to like prepare your own epi drip if you're in the community, like I mentioned. Dr. Kosowsky, any thoughts before we start talking about transcutaneous pacing?
Yeah, if you just want to go back, like maybe go back 2 slides and just as a reference.
Yeah.
You know, whenever you see you know, lots of different options for treatment of things, it tells you that none of them are perfect. So, you know, there is no magic bullet, and which is why in many cases you do have to move on to electrical therapy. It can sometimes be helpful as a way to temporize, or in particular circumstances, like for example, a patient with very high vagal tone. So atropine, again, atropine is very little downside to using it, but don't expect miracles. Isoproterenol is a good drug. The problem with isoproterenol is, at least in most places, it's just hard to get. You don't have pre-mixed bags. When we had to get it, we had to be specially mixed up. But we were fortunate to have a pharmacist on site to do it. But it is really a pure beta 1 agonist, so it's a pure chronotropic play. Without, if you're not sure whether this patient is overly vasoconstricted or not vasoconstricted enough, it's sort of, you don't have to worry about that. It's just going to give you the beta 1 chronotropy. But again, there may be situations where you might, you know, reach for epinephrine or dopamine as well, depending on what's available and, you know, what else is going on with the hemodynamics. But I guess as a general rule, none of these things are all that good, which is why there are so many options.
Exactly. So we'll talk a bit about kind of the pearls and pitfalls of transcutaneous pacing for unstable bradycardia, and talk about some of the barriers that we ran into in this specific case. So one important thing to note, you know, anytime you're using the Zoll, is that pad placement is really important. Specifically for transcutaneous pacing, the anterior posterior pad placement is typically preferred. And in this case, with our patient, we think that the anterior pad might have initially been a little bit too low. So you ideally want to put the anterior pad in the lower part of the left sternum, kind of over where you would put the ultrasound probe for like a parasternal long window. And this is thought to be the best point of contact between the heart and the soft tissue of the chest for delivering electricity. Another pitfall to talk about is the current that you're delivering. With our patient, we had to do quite a bit of troubleshooting with the amount of current and you know, the number of milliamps that we were using to try to get electrical capture. Long story short, the ideal window for capture per the literature is typically 40 to 80 milliamps. I think with our patient, we ended up having to increase to around 80 to start getting, you know, evidence of pacer spikes for electrical capture. This will also be dependent on body habitus. So if you have a patient that is, you know, obese, you might have to go even higher than that. Based on my understanding and some of the reading that I did for this lecture, it sounds like it's never wrong in an unstable patient, you know, to increase the milliamps up even higher until you start getting evidence of electrical capture, and then you can, you know, dial it down. But you always want to aim between like 10 to 20 milliamps above the minimum energy that you see where electrical capture starts, and ideally continue pacing with that current. And then this is also just a teaching point to highlight. There's this notion of pseudo pacing, and don't be fooled by that if you have a patient with bradycardia and you're transcutaneously pacing them. You may see like a monitor with a heart rate that doesn't suggest that the patient's bradycardic, but then on the pulse ox tracing, you can see the true pulse. So there will be a disconnect between those. And the underlying reason is that the pacemaker with your pads is not capturing the myocardium, but the monitor displays a heart rate that's equal to the transcutaneous pacemaker. So just be mindful of some of these pitfalls. And then again, confirming electrical capture, you want to look for your pacer spike and widened QRS, and confirm that there's mechanical capture as well by looking for distal pulses, like in the femoral region, or DP pulses. Dr. Kosowsky, any comments on these points?
Yeah, I think we fell victim to that as well, because if you look at the monitor again, it looks like there's capture sometimes.
Yeah.
So either the pulse ox or feeling a pulse, if you're feeling up around the neck, sometimes you'll actually feel the contractions of the chest wall as pulses. So that's why it's important to be palpating for pulses distal from the chest wall itself. And to Lindsay's point, we'll talk a bit later about sedation, but you may need quite elevated milliamperage to get capture. Patients who are obese, patients with COPD, patients with pericardial effusion, all the reasons that impedance may be higher could come into play.
Yeah. And then, in addition to transcutaneous pacing, we also have transvenous pacing, which you can progress to in cases of unstable bradycardia that don't respond to your medication interventions, or if you're unsuccessful with transcutaneous pacing. And then also in cases of high risk blocks that leave the patient at, a pretty severe risk of further deterioration. So this is, I don't think we're going to play the whole thing, but I can at least start this just to show some of the elements involved in transvenous pacing, especially for our junior residents. So let's see if this works.
Placing a transvenous pacer is pretty much exactly like putting in a big central line in the right IJ, with the only difference being that we're putting in a single lumen, big old cordis line in the right IJ instead of, say, a triple lumen that you may more typically use. And then through that single lumen, we're going to put in a pacing wire that's going to go all the way down to the right ventricle where it's going to pace the heart. So you got this. You can totally do this. Now we want to use either the right IJ or the left subclavian as the preferred sites because they're the closest to get to the heart, but also check this out. That curvature of the wire, we're going to use that to our advantage. So if you go through the right IJ, it's going to curve towards the heart. And if you're coming across the left subclavian, again, it's curving towards the heart. If you can, use the right IJ instead of the left subclavian so we can use that for the permanent pacemaker. Now, the only hard part about this procedure is remembering what gets connected to what are the settings that you're going to put on the pacer generator, and the pattern on the cardiac monitor that we're going to look for to know that we are in the right ventricle for sure. But don't worry, we got your back on all those things. So let's start by looking at a quick schematic overview of ventricle. The pacing wire comes out the SVC and through the right IJ where you placed it. You have a sterile sleeve over the top of the sterile pacing wire. This syringe inflates and deflates the balloon, and then through adapter pins, it plugs into the connecting cable, which goes into the pacing generator. So once you consent your patient, and we already had an informed discussion, you're going to sterilely prep and drape your patient, and then you're going to put in that right IJ line. I'm just going to assume y'all know how to do that part, so let's jump ahead. Once you got your corded IJ, now you can remove the wire and the dilator. You can do this all in one motion. Plug the connecting cable into the pacing generator. This is typically sterile. This is not. So you want to have a non-sterile assistant help you with this. Ours can actually be atrial or ventricularly paced, but we're putting this in the RV, so I'm going to plug this into the V. Now that the connecting cable is all set up, we're going to check the balloon on our pacing wire and make sure that works. So you're going to use this small syringe and the one with the plunger. I mean, this can't draw up any more air than what it allows, and that's a good thing because you don't want it to rupture the balloon. So we're just going to confirm that our balloon actually does inflate. And then you're going to deflate the balloon, keep the stopcock open, And now we're going to use our sterile sleeve. So the sterile sleeve direction really matters. This side is going to connect to the cordis, which means that the wire has to feed through it this way. So we're going to feed the wire. Take time to recruit some help and get a subxiphoid view. That way you can watch this wire going into the RV. And remember, we're following the curvature of the wire here, so it curves into the right ventricle.
In the essence of time, is it okay if we move on? And I'm happy to send out this MRAP video to folks. Anybody? Can people still hear?
Yeah,
Okay.
sounds
All good.
Okay,
We're giving
perfect.
thumbs
Just
up.
because it's long. Okay. Great. So I think now is a good time to talk about sedation choices, which was also a good learning point for us in this case. Dr. Kosowsky, do you want to chat a little bit about this aspect?
Yeah, thanks, Lizzie. So as alluded to, you're often you find yourself between a rock and a hard place in a patient who needs to be paced, because if you're thinking transcutaneous pacing, and the patient is still awake, that is it's definitely uncomfortable. And we definitely saw that in this patient as well. When we started pacing, that even with sedation, he was still extremely uncomfortable, which can limit your ability to effectively get capture. And at the same time, many sedating agents have hypotensive responses. So in this case, we had atominate in the room because we were anticipating the need to potentially intubate the patient because he was so unstable, but we couldn't intubate him until he was stable enough to have a blood pressure that wasn't going to crash with intubation. So we often find ourselves in these sort of a catch-22. In retrospect, I wish we had chosen ketamine. I think that would have been a better choice. It also has vagolytic properties, and so it can increase heart rate. It has very little, if any, effect on blood pressure. If anything, it can raise blood pressure, and it's easier to titrate. So uh, the uh, the choice of sedating agent is important. The nice thing about ketamine as well is that it has analgesic properties, so you don't have to also give something like fentanyl for the pain. In this case, we did use etomidate. We used enough etomidate to sedate him to the point where we were able to get capture. At that point, we were sort of forced to intubate him because he was essentially, he was still breathing, but he was not protecting his airway. So it made the decision to intubate very easy. But we might have been able to get away without intubation if we had titrated ketamine appropriately.
Does anybody have questions or thoughts about sedation? Okay. So talking about the outcome of this patient, luckily it was a successful one. So the patient was taken emergently from the ED to the EP lab with a plan for a permanent pacemaker. Unfortunately, he remained hemodynamically stable in the EP lab initially. I apologize for the typo. They placed a temp wire instead and admitted him to the CCU. While he was there, he had stable interval CT scans of his head, and his anticoagulation was held. And the following day, he underwent successful pacemaker placement and was extubated. And he was discharged home with his permanent pacemaker after an 8-day stay in the hospital, which is, given how bad he looked, is pretty positive to hear. So just a couple of points to summarize some of the comments that we were making. In cases of unstable bradycardia, a normal blood pressure does not necessarily equal adequate perfusion, which is important to remember. A patient might seem like they're doing fine, but they could be vasoconstricting to maintain a normal blood pressure despite organ malperfusion, which you might see through like an elevated lactate or mental status changes, as we talked about. anytime you have an unstable patient, this goes beyond bradycardia, being able to work through multiple treatment options and, a differential diagnosis, of course, is important. Bradycardia, for example, could be due to ischemia. It could also be due to a whole host of medications and tox metabolic presentations. And on that note, in cases of bradycardia, fixing the heart rate may not be enough to kind of fix the patient's overall picture and presentation. So again, keeping in mind if they have an underlying MI or ischemia, getting them definitive interventional treatment, is the gold standard. So just keeping that in mind as you are working to stabilize them is important. And again, we have some nice infographics just to highlight some of the reversible causes of bradycardia. And I will let Dr. Kosowsky chime in with other thoughts and pearls from this case.
Yeah, awesome. So first of all, again, thank you, Lindsay, for presenting the case, and even more importantly, for being involved in the case when you were there. We were having an extra set of hands and another thoughtful mind to think through what was a really complex case was very, very helpful. We've been focusing on the bradycardia and shock aspect, but this was also a trauma, and this easily could have been, and maybe in retrospect should have been called out as a trauma. I mean, after all, an elderly guy on anticoagulation with a head injury. One of the challenges, in retrospect, with that we were managing this case in room 49, which is better than managing them in the hall, which sometimes patients like this end up in. But still, when you think about, having where we've got not only, all the different personnel, but we've got transcutaneous pacer, we've got intubation equipment, ventilator, drug cart with the pharmacist. It was a lot to do in a small room. And in retrospect, you think, gee, I wonder if we had done this in the trauma room, that might have been easier. At the same time, in the back of our minds, part of our concern was that, we had sort of an undifferentiated trauma, and he was an anticoagulation. So, we were obviously concerned about a head injury, but he could have had other trauma as well. And maybe that was at least in part responsible for a shock. So there was sort of a real sense of urgency to stabilize him to the point where we could get him into the scanner to make sure he didn't have, intraperitoneal, interthoracic, or other types of bleeding. We had done a fast exam. I don't know if that appears in some, so we were pretty sure that we weren't missing any major hemorrhage, but that was also sort of weighing on us as we were going through the case. So overall, I mean, I think some really important lessons learned. Lindsay used to summarize them very well. But we have a few minutes left, so if people have questions or comments or other thoughts, please unmute and let's have a conversation.
I have a question. Thank you guys so much for presenting that. Super interesting. And I feel like we don't see a ton of or at least I haven't seen a ton yet of super unstable bradycardia. So I was just wondering, I know we're pretty spoiled with having an EP lab here, but I bet there was conversation about when to convert to a temp line. And I was curious, especially if we weren't at, say, the Brigham, we were out in the community, what that conversation was like and kind of what your decision tree is for that.
Yeah, I don't know that there's one right answer. In this particular case, one of our other concerns was that he was anticoagulated, so putting in a central line was not without some risk as well. I think in the community, many times, if you can get capture transcutaneously, you'll be happy with that, and you'll transfer the patient somewhere where they can put in either a temporary or permanent pacer. If the patient's going to be with you for a while and you have the resources, transvenous pacing is more reliable over the long term. But I think it's just going to depend on the circumstances. I've definitely seen patients transported being paced transcutaneously. You're probably going to need to have that patient sedated and most likely intubate the patient for airway protection if you're going to go that route, though.
A great question.
Can you all talk through two different sort of decisions? One was the choice to start with dopamine. I know that isoproterenol was not readily available, but why dopamine over something like epi? And then if you could clarify, like, was the decision not to reverse anticoagulation related to the need for pacing, or was that just he was far enough out from his last dose that we thought it was unnecessary?
Yeah, so the decision about doping with epinephrine, it really is a coin flip, but we could have done one or the other. Cardiology had recommended that they were at the bedside, and that's what we decided to start with. I don't know that we would have had any more effect from epinephrine. When you think about it, if you add dopamine to isoproterenol, you're essentially getting epinephrine anyway. But yeah, I mean, if you're out in the community and you're more comfortable with epinephrine, I would definitely go with that. As far as not reversing him, I think that was more the question that the patient was obviously at risk for embolic events. He had AFib, and now he's got a wire in place. And so you're always doing a balance. When you do reverse a patient, it puts them into a hyper coagulable state, at least for a period. And given the fact that this patient's intravenous hemorrhage was relatively small and stable, I think the thought was let's err on the side of keeping him anticoagulated rather than coagulopathic. But it was a judgment call. It wasn't a straightforward decision.
I have another question. It's less related to bradycardia and more to like syncope workup. Just because this was a case for me, similar kind of case for me the other day. This patient came in without any chest pain after syncopizing. I noticed you guys still got a troponin. Is troponin like part of your initial syncope workup, or kind of, because I know it's elevated, and then like, what do you do with that?
Yeah, in general, getting a troponin isn't, it's not all that helpful. If it's not a picture of an acute coronary syndrome, you're probably not going to learn a whole lot. That said, just yesterday, we had a patient coming in. I don't know if anyone was on yesterday at the Brigham. Middle-aged guy was walking to his group home, collapsed, was brought in by EMS, had like a borderline blood pressure, had no complaints at all, was probably an unreliable historian. I was working with a medical intern who was like, "Hey, should we get a troponin?" I'm like, "Yeah, why not?" Go ahead, get a troponin. It came back at 170, and not because he was having an acute coronary event. His EKG didn't show any ischemia, but it turned out like we did a bedside cardiac ultrasound, and the guy had 15% that had never been diagnosed. So it was basically like first diagnosis of heart failure in a schizophrenic patient who was like had his heart failure, his EF was like 15%. It was so low that he basically wasn't perfusing very well. So when he went outside and walked around, this was not his first time collapsing either. So, there's no rules about when to do it, but just I think it's more, you can get it whenever you want. It's more about how do you interpret it, what's the context for interpreting it. And a patient who's in shock is probably going to be elevated if for no other reason than because of demand, sort of a supply-demand mismatch. In this particular case from yesterday, it wasn't ischemia. It was just like myocardial damage from a guy with a terrible heart. In a patient who has ST elevations or ST depressions, it could be acute ischemia, but acute ischemia itself doesn't usually cause syncope without an arrhythmia. So yeah, it's case by case. Go ahead and get it, but just make sure you're interpreting in context.
Helpful, thank you.
All right. Well, again, thank you everybody for joining. Thank you, Lindsay, for presenting. Thank you, Aaron, for setting this up. And
Yeah, thanks everyone.
we'll make these slides available with all the links to MCRIT, and
Yes.
feel free to reach out to either of us if you have additional comments or questions afterwards. This was a lot of fun. Thanks for the opportunity.
Thank you guys so much. This was
Thanks,
super helpful.
everyone.
The slides were great. It was wonderful. We really appreciate you guys.
Thanks,
And
y'all.
Lindsay, you're gonna have to teach me how to use Canva one day.
I will. I'm a big Canva fan. We can go through it.
Awesome. All right, everybody, have a great rest of
Bye,
your day.
guys. Thank
Bye,
you.
everyone.